So I'll be briefly summarizing and discussing about the findings that we had during a multi-center observational study that we conducted to explore the genetic etiology of childhood cystic kidney diseases in India. So basically this project was started by Sir Rajiv Sinha Sir, Dr. Dipanjana ma'am, me along with other centers that have contributed. So we know that cystic kidney diseases are a heterogeneous group of kidney disorders contributing to the CKD burden in the population. They comprise nearly 6 to 7% of children with CKD as per various registry. Early detection and diagnosis of cystic kidney enables one to initiate the various nephroprotective measures, and FDA approval of drugs like tolvaptan has opened avenues for medical intervention in ADPKD as well as research into other cystic kidney disease. So, from India, we searched the literature and we found that there was no published data regarding the genetic spectrum of children having cystic kidney disease in India so far. So, we went ahead for this study with the objective to identify the genetic spectrum among Indian children with congenital cystic kidney disease and also to study the association of individual genetic variants with clinical characteristics of children with cystic kidney disease and explore the genotype-phenotype correlation. So it was a multicentric cross-sectional observational study which was conducted across various centers, ICH Kolkata being the nodal center, and this was done over a span of 2 years. And we did a convenient sampling, and we had originally planned to recruit some 100 children. So the inclusion criteria was any child less than or equal to 18 years of age with presence of 2 or more kidney cysts in ultrasounds of unknown origin, any child with one kidney cyst measuring more than or equal to 1 centimeter and with a family history of cystic kidney disease, any child with a proven genetic diagnosis of cystic kidney disease and also presence of at least one cyst, typical presentation of polycystic kidney disease, ARPKD, ATPKD, and prenatal diagnosis of large hyperechogenic kidneys and or renal cysts with or without oligohydramnios. We had excluded children who had single cyst without any external manifestation, without familial renal or liver cyst, any child with cystic tumoral process, and any child with multicystic dysplastic kidney. So we had enrolled the subjects after taking informed consent. Detailed demographic and clinical data was recorded along with the relevant lab parameters and imaging parameters, and 5 ml blood was collected stored in EDTA vials at a temperature of 2 to 8 degrees Celsius, and then DNA extraction was done till analysis. And analysis was done by whole exome sequencing, and we noted down which all variants were likely pathogenic or VOS variants that were reported after establishing genotype-phenotype correlation, and also we did a parental segregation. So what were the results we got? We had recruited 117 children from 15 centers across India and also 2 centers from Bangladesh. And we found that there was no difference in the male-female preponderance of cystic kidney disease. And we had children ranging between 4 hours after birth to 18 years of age with a median age of around 77 months, IQR of 19 to 132 months. We found that out of these 117 children, we could identify pathogenic or likely pathogenic variant in 68 children. Variant of uncertain significance we could find in 32 children, out of whom 15 had variants which were reclassified into likely pathogenic, and 17 still remained variant of uncertain significance, and no related variant or no variant was reported in 17 children. So overall the yield was around 71%. We found pathogenic or likely pathogenic variants in 83 out of 117 children. So what were the genes that we most commonly noticed? So we found that ADPKD was the most common genetic diagnosis. 26 children had, accounting for 22%, followed by autosomal recessive, followed by nephronophthisis, syndromic, non-syndromic combined. This was present in 19 children, accounting for 16%. ARPKD was found in 16 children, accounting for almost 14%. And then there were other genetic diagnoses also, like Bardet-Biedl syndrome, tuberous sclerosis, contiguous gene deletion syndrome with a TSC2 and PKD deletion. We found 3 HNF1 beta pathogenic children with HNF1 beta pathogenic variants. We found significant number of children with 17q12 deletion syndrome, which were seen in 5, which accounts for 6% of our cohort, and surprisingly, one child with Gentleman syndrome who had presented with familial hypokalemic periodic paralysis. The child had that, another brother had it, and they were found to be having cysts, and the genotype revealed that it was a pathogenic variant of SLC12A3 presented homozygously. Now, among the ADPKD pathogenic variants that we found that PKD1 was present in almost 88% of our children, and PKD2 was present in around 12% of our children. We did not find any other gene responsible for causing ADPKD reported as pathogenic or likely pathogenic. And in the 19 children who had nephronophthisis, there were almost 14 who had non-syndromic nephronophthisis. NPHP1 was there in 9. ILV is responsible for causing infantile nephronophthisis in 2, and NPHP4, isolated NPHP4 in 3 children. And there were 5 children who had syndromic nephronophthisis, out of which 2 children had NPHP4 related serial locate syndrome. 1 child had NPHP3 causing renal hepatic pancreatic dysplasia. This child had actually presented with hepatic cyst, hemangioma, and bilateral renal cysts. And we found 2 children with Joubert syndrome. One had TMEM67 who had antenatal presentation, and the one who had, the TMEM67 had antenatal presentation and presented within 10 days after birth, and the other child with GR1P1L variant. This child was detected to be having CKD at 6 years of age, and the child also had many CNS manifestations which were not for which they did not take any medical advice. Now, regarding the pathogenicity, so in the NPHP1 genes, we found that out of the 9 children whom we found were having NPHP1, all of them were having pathogenic variants. So the incidence of finding a variant of uncertain significance was much less in the variants which we found in the NPHP1 gene. This was followed by TSC2. So we had actually phenotypically identified tuberous sclerosis in 6, out of which, total 9, out of which in 5 we found that they had only TSC2 involved, and the rest 4 had contiguous gene deletion syndrome. And in the 5 kids who had TSC2, 80% had pathogenic, and only 1 was reported as variant of uncertain significance. But the incidence of variant of uncertain significance was much high in PKHD1 and the PKHD and the PKD1, PKD2 genes. So, and when we looked at the type of variants that we found in the various genes, we found that the missense variants were the most common among the abnormal variants found in PKD1. Also, they accounted for a significant proportion of children in PKD2 and also in PKHD1. Whereas in case of Bardet-Biedl syndrome, we found that the incidence of this truncating mutations and also deletions were much higher. And probably that accounted for that we found that 4 children had a BBS phenotype, and all 4 of them had pathogenic variants reported in the BBS gene. Now, I would shed a little bit of light about the individual genetic diagnosis that we found. So, in ADPKD, we found that 13 children, that is 15% of these children, had an incidental presentation. Whereas, we found that antenatal presentation was there in 5 children, which accounted for 20% of our population. 3 children had presented with only failure to thrive without any hypertension with normal renal functions. And there were 3 children who presented with deranged renal function, and 2 out of these were quite young in the infantile age group. And 1 child had presented with gross hematuria at around 8 years of age without any hypertension with normal renal functions. And 1 child had presented only with hypertension with normal renal functions and with no other clinical manifestations. And in our population, we found that de novo variants were reported, pathogenic variants were reported in 5, which accounts for 19% of our children. And we found that out of these 26 children who had the genetic diagnosis of ADPKD, only 6 children were hypertensive, despite most of the children having more than equal to 4 cysts bilaterally with enlarged kidneys. I don't yet, as of now, have the kidney Z scores with me, which will help me to find out the correlation between the genotype and the kidney Z scores that I'm doing. I'm in the process of doing that. And but one thing I could notice is that in the children who had incidentally diagnosed ADPKD, either because they were found to be having bilateral cysts due to during an imaging done due to abdominal pain, or were actually having some family member positive, and that's why the ultrasound was done. All of them were actually having some heterozygous variant. Whereas the 5 children who had antenatal manifestation, 3 out of them had a compound heterozygous state, and even one among them had an associated PKD2 along with the compound heterozygous PKD1 variant. So actually 3 genes of PKD contributing to it. And we unfortunately don't have the total kidney volume noted in any of this, so I cannot really find the correlation between the total kidney volume versus hypertension, renal functions, or genotype in this cohort. Now regarding ARPKD, we found that 2 children had presented only with renal manifestation. They did not have any hepatic involvement as such. One of them was around 1 year old, the other around 5 or 6 years old. And 10 children, they were found to be having both renal hepatic manifestation, that is where the renal manifestation was like failure to thrive with polyuria with or without CKD. And there were 4 children had renal without hepatic involvement, and 2 children actually had hepatic involvement. Both of them were around, I think, more than 15 years of age. And they were found to be having kidney cysts on ultrasound. They did not have any kidney manifestation as such. And antenatal manifestation was there in 8, that is 50% of these children. They had bilateral enlarged kidneys with increased echogenicity, with or without cyst, with or without oligohydramnios. And those who had presented postnatally, the rest 8, 4 had CKD with or without hepatic manifestation. 1 had failure to thrive and polyuria, 1 had only hypertension, and 2 had incidental, which I already discussed. And bilateral enlarged kidneys was there in 12 children. And I found that as the children aged, like maybe in children more than 8 years of age, I found that the incidence of finding bilateral enlarged kidneys were less. Now about the nephronophthisis, I have already elaborated about what genes we found. Males, there were 11 children with nephronophthisis who were males, and rest 8 were females. Non-syndromic in 14, and the rest 5 had syndromic manifestation. Antenatal manifestation was there in 9, and all had polyuria, failure to thrive, CKD with or without typical external features. None of them had hypertension. So then I tried to find out what was the genotype-phenotype correlation like. So these last 2 slides are. So we found that in those children whom we had thought that the phenotype is like ADPKD, there were 40 such children. It actually turned out to be ADPKD in 25. 3 turned out to be HNF1 beta, 2 turned out to be 17q12 deletion, 6 had undetermined, like we could not make the genetic diagnosis either because they were having variants in PKD1, PKD2, which were reported as VUS, which we could not reclassify, and we could not find any variant in 4 children. Again, in ARPKD, there were 31 children who we thought that they are having the phenotype of ARPKD. Out of them, 16 actually turned out to be ARPKD, 1 had ADPKD, this was an infant. 1 had 17q12 deletion syndrome, 1 had Bardet-Biedl syndrome, which we this was again a young child, around 2-3 years of age. And then we went back, we did a expanded phenotyping, and we saw that the child was actually having retinitis pigmentosa. 1 child had Joubert syndrome and 1 child had contiguous gene deletion. Again, this was an infant in whom the other manifestations, the extrarenal manifestations of tuberous sclerosis had not yet appeared. And 7 had VUS, which we could not reclassify, and 3 children did not have any variant at all. So genotype-phenotype correlation is not that good in ADPKD, ARPKD. Whereas in case of nephronophthisis, it is better. So 22 we had phenotype of nephronophthisis, out of which 18 turned out to be nephronophthisis, 2 were negative, 2 had VUS. And out of the 9 children who had TSC, we found that 5 actually turned out to be having TSC, 3 turned out to be contiguous gene deletion, and 1 was negative, despite having the typical manifestations of TSC. And one thing that I found, whether there was any difference in kidney size, the other renal manifestations, I could not find any difference. But one thing was remarkable: all children with contiguous gene deletion had hypertension, whereas those having only tuberous sclerosis, even if they had bilateral multiple cysts, none of them had hypertension. So concluding it, genotype-phenotype relation was variable. So it was fairly good in F1 not that good in ADPKD, ARPKD. Yield was variable depending on the gene. ARPKD, ADPKD had a high rate of variant of uncertain significance. PKD1 had a significant high rate of variant of uncertain significance. Hence, family studies and clinical correlation are really needed to classify variants.